We have a very full agenda today. And so, for all of those people who are going to be testifying, if you could please err on the side of brevity, and then that way it allows for the committee members to ask questions and flesh out some of your topics in some more detail. So today is Wednesday, October 13th, 2021. This is the Child Welfare Oversight and Advisory Committee meeting. Before we call the roll, I just do want to remind members that please explain where you are and how you are participating in today's meeting for LRC staff. And then everyone, please be muted unless actively speaking in the meeting, and please use the chat feature to notify staff if you want to be recognized for a question or a comment. Before we get started with the roll call, we do have a few special guests with us today. We have Chairman Kim Mosier, we have Chairman Jimmy Higdon, and we have Representative Ken Fleming. I knew you were here somewhere. I was trying to identify you. Okay, Secretary, please call the roll.
Senator Byrd.
Present remotely from the district.
Senator Harper Angel.
Present remotely in the district.
Senator Storm.
Present remotely from my district.
Senator Westerfield. Representative Banta.
Present remotely from the district.
Representative Raymond. Representative Stevenson. Representative Tate.
Present from my district.
Representative Beckler.
Present in the room.
Chairman Meade. Chairman Rocky Adams.
Here. All right, thank you very much. We are constituted to do a little business today now that the roll call is done. First order is the approval of the minutes from our August 11th, 2021 meeting. Do I have a motion?
So moved.
Do I have a second? Do I have a second? I'll second it. All those in favor signify by saying aye. Aye.
Aye.
Any opposed? All right, the minutes are approved. We're going to go a little out of order today, just because of time concerns and people needing to be other places. First on our agenda is Senator Jimmy Higdon, and he wants a few moments to express his sentiments to the committee.
Yeah, thank you, Madam Chair, for allowing me to speak. April 13th, 1970. Many of you won't remember that date, but now famous words were spoken from Apollo 13. Houston, we have a problem. Members of this committee, Governor Beshear, Cabinet of Health and Family Services, members of the Kentucky General Assembly, we have a problem. We have a crisis. Last week, a young lady from my district asked if she could meet with me concerning social worker issues and the stress that they were under and the issues that they were having. I agreed, and we agreed to meet yesterday, Tuesday. She called me on Monday and said, can I have some other people, other co-workers that would like to attend. Is it okay if they come? I said, sure. When I walked into the meeting room yesterday, there were 13 people there, along with Representative Tom Birch from Jefferson County, and 25 to 30 people online wanting to meet with me and to speak. And probably in the 19 years that I've been in the General Assembly, that was the most passionate plea that I've ever heard from people, from state employees or from anybody about what was going on in their profession. A passionate plea that we need help. Kids' lives are at risk. And that's why I bring this message to you today, because I believe them. For example, Monday in Jefferson County, I'm told, It's not official record, but I'm told there were only 7 social workers on duty in Jefferson County Monday. I don't know if that's true or not, and I'm sure that's true to some extent. Somebody might prove me wrong with some other official record, but I was told 7 social workers were on duty in Jefferson County. That's all that was available to help children that were in crisis. That is a problem. And it can't wait till the next General Assembly to solve that problem. We need help now. Governor, Cabinet of Health and Family Services, you have the tools to deal with this now. And in the General Assembly, I think I speak for everyone, we're willing to help you. This is not a partisan issue. This is about kids, and this is about the social workers that are trying to help them. So there's a lot of reasons that I hear about their stress. We passed legislation and went home feeling good about it that we appropriated money for additional slots for social workers. But the pay is not enough, and when we do recruit social workers, there's people out there. I understand some of our MCOs are very, very happy to recruit those folks away from us after they're trained and have some time on the job. They make great employees, and they're able to pay them a lot more than what they're getting paid with the state. So we have 2 different types of. We have those dedicated public servants that have been with us for years. We have them, and we have a few at the 2 years and below that are being recruited away, and it's causing a lot of stress. We have people we have people retiring. We have people taking family leave and medical act leave, FMLA leave. We have people that are taking mental health days just due to the stress. And so I don't know what we do. I don't have the answers. I just thank you for allowing me to come and say these words today. I know the cabinet and a lot of other people will be here today, but my plea is please support these social workers and that are out there to protect our children that are in harm's way. And Madam Chair, thank you for allowing me to say those words. There's a lot can be said about this issue, and I know that you have a lot on the agenda today, and thank you all for listening to my passionate plea. Like I said, I was certainly touched yesterday. Thank you.
Thank you, Senator Higdon. And it's just so nice because it comes from the heart. And so we appreciate you giving us that update from your meeting. And it's going to be the focus of the committee today. And so your input has been very valuable. Thank you. Next up, and don't be concerned. I'm moving the agenda around because some people can join at various times. And so next up, I want to bring 7 County Services Child Welfare Workforce up to the table. Are they at the table or remote? Okay, looks like you all are remote. So we have Abby Drain and David Weathersby. If you all could introduce yourselves for the record, and please proceed, and just know that we are very tight on time today.
Okay. Thank you so much, Chairperson Adams and Chairman Mead, and members of the Child Welfare Oversight and Advisory Committee. Thank you for letting us share here today, and a personal shout out to Senator Adams, because I've worked with her closely over the last 6 years. She spends a lot of her personal time supporting children in our region. My name's Abby Drain, and I'm the president and CEO of 7 County Services in Bellwood and Brooklawn. And David, can you introduce yourself, please?
Yes. Good afternoon, everyone. My name is David Weathersby, and I'm the Chief Operating Officer for 7 counties. And I would also like to introduce someone to you. And Shelby, why don't you introduce yourself to the group?
Hi, thank you. My name is Shelby Greer. I am originally from Tennessee. What brought me to 7 County Services is I had been homeless for a few years. I was adopted at a young age. I had no family, no friends. I came to Job Corps in Simpsonville, Kentucky, 2018, completed there, still had no stability. In 7 counties, they have helped me as a single mother of one son, continue with the hope of helping me with my first apartment, so that I can continue with my life and my goals and everything. And yeah, so.
Thank you so much, Shelby. I hope what we bring to you today and share with you helps us improve the life of our most vulnerable, most at risk children. I mean, that is what I'm serving out the rest of my life in ministry in, is the exact work of this committee. I want to first give you an agency overview, and then what our vision is for our system of care, and then how the Families First Act blends in with that so well. So Seven County Services is partnered with Bellwood and Brookline, and Seven County Services serves over 30,000 individuals a year in our region, and we're the largest of Kentucky's community mental health centers, and we're centered out of Louisville, Kentucky, been around since the 70s. We have about $100 million budget. We have over 1,300 staff that are providing direct and support services to those living with mental illness, substance abuse disorders, developmental and intellectual disabilities. And we're really funded by Medicaid, state contracts, and federal grants. Bellwood and Brookline, they have a 170-year history. They serve about 1,000 kids a year. They're prior faith-based orphanages with over, like I said, 170-year history. And they fall back with the United Church of Christ and the Presbyterians. It's a great history on this as orphanages came up through our faith-based partners. They serve psychiatric residential treatment for children. So they're here 3-4 months to a year. We do family preservation work, which was my favorite. It goes along with the Families First Act, and it prevents children from ever coming into care at a 95% rate. Transitional living work is also work we're in, where we work with the younger youth and help them in their 15, 16, 17-year-old to try to develop the skills that'll help them be successful as adults. We have independent living, which says the kids already turned 18. Now, how can we help them further develop those skills for 3 years? We do therapeutic foster care, and we do that work with, from 0 to 21 years of age, but mostly within the range of 6 to 18. The children that we serve at Bellwood and Brookline are the older youth. They're not ones that people are waiting outside the doors to get when they turn 18, nor wanting to adopt or foster children at that age. Mostly they're like younger kids. But our older kids are wonderful kids. And sometimes when they get older, they're not wanting to be adopted and call somebody mommy either. They've been through this system for quite a few years, and they really want to be able to strike out on their own and be successful, just like any other 18-year-old. Our system of care vision, we've actually hired some great people, and we're working on building that system and closely connecting it with the Families First model that's coming out of our cabinet for health and family services, mainly through the Department of Community-Based Services, Medicaid, and Department of Behavioral Health. We're wrapping all these pieces together, and we want to be able to assess and provide the appropriate mental health and substance use disorder services. We want to, at most, keep families together, prevent them from ever coming into care by working with them early and working with their mothers and fathers or who's ever in their family structure. If the kids remain, if they get taken out of care, out of their family home, then we want to work to reunite them with that family if at all possible. If that means parents go into treatment of some kind, short-term treatment. If the children remain in the foster care system, then we want to do all we can to help them build those skills up that we all had, and that includes trust. And it includes skills like reconciling your bank statement and knowing not to sign up for every credit card that comes through the door. Those are the kind of things we look at, and we look at age appropriate care. But this work we're going to do with our system of care, will really wrap services around those youth that are ready to be transitioned back to the community and need some extra supports. I've seen so many children come out of our great care at Brooklawn and Bellwood only to not be successful out in a home, because those parents take those kids in and they want to do their best, but these kids need a little bit more structure around them. They're still living with that trauma from early childhood and trauma if they're going through the system and being removed from their family members and maybe moving around to lots of places. So we're going to build what we call our new pathways model. And I know David's going to get into that a little bit more, but it'll help those 18 to 21-year-olds that sometimes just want to be dropped off on the street. And we know that that's not where they should be. They've come out of this foster care system. They may have not gotten all the support they needed, and their education may not be polished off with that high school degree and ready for college. And that's the work that we want to do around these youth and give them something really to look for in the future. Our vision looks at a 25-year-old young person and says, where should they be at in life? Where should they be along that path? And what do we need to build to get them there? So that is exactly what we think about at Bellwood and Brooklawn, coupled with the great might of 7 county services, our own community mental health center, and the number of providers that we can take and wrap around kids, the crisis response that we can provide, the psychiatric services, and hopefully those job skills and job training services that we want to instill in kids. Now, we love the Families First Act, and whatever you can do to support that, please do that. But we also know with that great work that's going to go on, we'll see the future change. We're already seeing the future change and not as many kids coming into the system. But as I look at it, we have from 10-year-old to 21-year-old that we need to serve and are going to be serving for the next 10 years through this system. Instead of delivering broken children out onto our streets and in our communities, we want to help build those real strong, resilient young people like myself. If you know anything about my history, that person that can go through school, that can raise children, and they not become children that wrap back into the system and go on to be great neighbors and great leaders in our community. So we can't forget about these children. And now what I'd like to do, Shelby shared some of her story, and we're so thankful that she joined us today to talk from the heart about what those experiences have been to her. Can I go on and pass this on to David Weathersby, and he's going to fill us in more on exactly the kind of work we're doing. Thank you.
Please proceed, David.
All right, thank you, Abby. So, so we're talking about building in our region a system of care around these young people, and specifically today, we're talking about those 18-year-old to 21-year-olds. I was so happy that Shelby was willing to share her story with you, because Shelby is an example of the good time, of the good side, when things work out well and people get the help that they need. I've been in this field for over 30 years, like many of you have, and I've seen many young people that haven't had the same opportunity. And those are the kids that we're talking about today. We're really talking about, in many ways, they're called the lost generation, because a lot of times they'll disappear from services when they graduate from high school or around high school. They kind of disappear, and we don't see them for a while unless they come back through the legal system, through the courts, or somehow they end up in a hospital. And so these are the folks that we're really trying to talk about today, and that we really want to focus on. There's 3 specific areas that we want to really hone in on or ask about in terms of help that we need for. The first of those is our Family Recovery Court. As you may know, there are 2 family recovery courts in the state. One is in Jefferson County and the other is in Clay County. Those programs are limited in their funding, and it's primarily private funding that runs those programs now. They serve this very generation. This is the young people who disappear from services, who end up in the system, often involved with Child Protective Services and legal issues and in family court. They often have substance use issues, and we have the opportunity then to intervene with them. And we've been running a program in Louisville, Family Recovery Court, for 3 years, and we've had a lot of success in reunifying children with their families. And this has been a partnership with the cabinet, and it's been a very successful partnership. But to this point, we've been dependent primarily on private funding, and we really need, the whole state needs to look at a Family Recovery Court as an option. So that's one thing we wanted to talk about. The second, which Abby mentioned briefly, is Pathways to Success. And that's a program geared at these young people that are aging out of care, who really have a very few places to turn. As many of you know, right now in Louisville, Kentucky, there's about 1,000 homeless young people between the ages of 18 and 25. At any one time, you will see those young people about. We try to help those people through our drop-in programs and through our ACT teams and those types of things. But if we could just give them more structure around as they're turning 18, as they're beginning to age out, we could keep them in services, keep them in treatment, keep them connected to their families, and keep them connected to a support system. We could prevent a lot of this homelessness, a lot of this overutilization of the system, and a lot of overutilization of the legal system. So that's another program that we're thinking about specifically. And finally, we wanted to talk a little bit about substance use as related to adolescents and young adults. I had the privilege of running a substance abuse program for adolescents for a number of years. And unfortunately, that program was called the Lighthouse. Some of you may have heard of that program. It was, at one point, it was one of only 2 residential adolescent substance abuse programs in the state. We had to close that program 5.5 years ago. It was a difficult situation because it was serving a lot of these young people that we're talking about. And since that time, there have been many other adolescent substance use programs that have closed in the state. And so we lift that up to you today as a concern. Honestly, these programs don't fit well into the traditional type of managed care continuum that we've seen in the past. The idea of limiting stays to 30 to 60 days doesn't work that well when you're talking about young people who need to change their entire lives. They need to deal with the academic part of their lives. They need to deal with their vocational futures. They need to deal with family restoration and family relationships. They need to deal with where they're going to live and finding a home. Hard to do that in 30 to 60 days. And so, again, our request, and to put it in your mind, is that we need to do more around substance abuse and co-occurring for our young people in the state, so that we can move forward, so that we can prevent the things that we're talking about. Thank you for your time, and we're open to any questions that you might have.
Thank you very much for your testimony. And I really appreciated hearing from Shelby. That was nice to have her on the line as well. We do have a question. Well, first of all, I want to say, I think the world of Abby Drain. I think you are a superstar, and I hang on your every word because I think you understand this area, how we can help kids, how we can do better, how we can have a holistic wraparound approach for helping kids and families. And so I'm just thrilled that you testified here today, and I look forward to continuing your counsel as we move through these very, very difficult issues. Representative Tate has the first question.
Thank you very much, Madam Chair, and I certainly appreciate the Abby Drain and Mr. Weathersby's testimony and being here today, and everything that they do for the children in our community. This question that I have is not a question that I prefer to ask, but that one that I feel compelled to ask. You know, over the interim, I have been working with a lot of nonprofits, And one of the things that I have been told that is, and so I feel compelled to ask this question, is that several of the nonprofits who have been not taken a position on reproductive care are choosing to take a position now because of the conversation that's occurring on the federal level, and with the Hyde Amendment not being supported on the federal level, even though it has in the past 40 years from a bipartisan perspective. So I would like to ask the two presenters if, and I understand that we're talking about children here, but I do want to know if they are planning in the very near future making a change in the reproductive care arena.
Making a change or making a statement. We have no plans to make a statement. Is that what you're asking?
Taking a
Taking a stand.
Or taking a position. Yes, up to this point, you have not taken any type of position or statement. Yes, ma'am, exactly.
I'll tell you what, Nancy, I have my own personal opinions on that, but we have not chosen to, we're sitting in the middle of COVID. That's no excuse, but I'm trying to keep a couple companies running, taking care of people with mental illness, addictions, and mental health disorders. There is just no even time for me to think about my own health sometimes, but that has not come up. We have not talked about taking any position there. We do take a position around behavioral health, addictions, and intellectual disabilities, and certainly around youth. We all know there are a lot of kids out here that need homes and families, and that's what I'm trying to do. Every child that comes into this world, wrapping our arms around them when they're in need, and that's where I'm at.
Thank you very much,
Thank you very
Abby,
much
for that answer. Are there any more questions from committee members? Representative Mosier?
Thank you, Madam Chair, and thank you very much for your presentation. I love hearing the great work that you're doing, and certainly support the Family First Act and the connection to services and so forth. My question is, are you seeing the same attrition and staffing shortage and high caseload that our state workers are seeing? And if not, what are you doing? Maybe you don't know exactly differently than some of the other, DCBS and some of the other social work providers. But I mean, what are you doing to retain your staff?
Yeah, well, if you didn't read the paper, we won Top Employer of the Year award. Just came out in the paper on Sunday. We were number 2 up against Norton's, but that's pretty good up against Norton's. We're doing a lot. And first of all, we start with trauma-informed care. We're a trauma-informed care entity, and we practice that amongst ourselves and with the people we serve. So we still are down a lot of staff. We're working really hard to be engaged in any kind of opportunities out there where they bring candidates together, job fairs. We're coming out in a big way with that, bringing our providers along with us. We're using social media all we can. And we're asking, I just got off a town hall with our staff, about 200, I think we're on that, and asked them to personally share on social media or call their friends, call their family members, and seek candidates. We've also did some pay increases. So we've tried to bring up the pay, especially our licensed providers and then our youth care workers at Bellwood and Brooklawn. We have closed the gap on our youth care workers, doing that very well, but we're still struggling with our licensed providers and some LPNs. But David is the real guy in charge of that, so I'm gonna let him add a few words there.
Well, I would echo what Abby said. You have to be willing to really try almost anything, and we certainly are. And so if there's a job fair, then we're there. If there's college classes that need a speaker, we're telling those programs that we're happy to speak with your students at any time you want. So we're trying to engage wherever we can. As everybody knows, the best way to bring new staff in is through the personal relationships of your people. And as Abby was talking about, we really stress that. We do pretty good significant bonuses for referrals, for self-referrals, for internal referrals, for new staff. We also use referral bonuses to try to recruit staff. But as Abby said, it's difficult right now. This is, in all the years that I've been working in this field, this is the hardest time we've ever had in trying to fill positions and hire people. And especially, you know, I see the two ends of the spectrum. The licensed staff, those folks are difficult to hire at this point. And then on the other end, those with lived experience. Even the pandemic has made that challenging for folks, and people are reluctant to step out. But you know, so we're learning along with everyone else during this time, and I think, you know, there's much more for us to learn. But we just try to be out there and open and engaging as much as we possibly can.
Okay, thank you for that. Next up is Senator Berg.
Thank you, Chairwoman Rocky. My question is specifically, I think, for Mr. Weather. And guys, thank you for an awesome presentation. You don't have to answer this question now. You can get back to me later. But my question is, what is it going to take to get good quality inpatient addiction care services for children in this state that will be covered by insurance? There's a desperate need. I know in my own family, there is a desperate need. It is not available. What do we need to do to make it available?
Well, we need for, my first response to that is that we need to advocate for Medicaid to work with our managed care organizations on how they approve services and on the rates that they provide. Frankly, the rates that are, you know, out there around managed care service for residential services for substance use, they're not enough to cover that expense. It's a much more expensive service than a traditional residential program with all the services that you have to provide. And so that's a good starting point.
David, I might add that we have the location and we have the facility to do that. And it is part of our strategic plan if we can get affordable rates. And we're not talking we make a lot of money. We're talking just covering the bare bones expense.
A quick follow-up. Could somebody supply for me what an average daily reimbursement needs to be from Medicaid to cover this service and make it financially feasible for us as a state to be able to offer these services to our children?
I'll be glad to send you that information.
Thank you.
And David, I actually think, Senator Berg, that's a great question. So David, why don't you just send it to the whole committee and we can distribute it, because that's good for us to look through. Thank you, Senator Berg. Next up is Representative Fleming.
Thank you, Madam Chair. I am not a member of this committee, but I do appreciate Chairwoman Rocky Adams and then Chairman Mead for allowing me to participate in this process, because I've been receiving several phone calls and emails on this particular issue as well as other issues regarding child care services. I want to ask, and I appreciate, the Senator Berg mentioned about, what it will take to increase the reimbursement. That's part of the answer, but I think the real answer is that we've got a pipeline problem. And the pipeline problem is basically not having enough people that are going to school to have more competitive pay to get them into these roles and so forth. So that's one thing. But I want to ask a question to Dr. Drain and Mr. Weathersby, and that is your answer to Representative and Chairwoman Mosier. And that was a good answer, but I was wondering if you can enhance your answer in terms of providing more of a substantial data in terms of what's going on. I just feel that there's underlying issues going on out there in the marketplace that's we're faced with. And I was wondering if you can give a little more explanation, a little more, I guess, meat on the bone, if you want to call it that.
I'm gonna try to answer it, and David, you pick it up if I miss it completely, because maybe you heard better. But the real issues have been around for a long time, and it has to do with our ability to compete with for-profit industry. We lose lots of staff to a for-profit industry, and our payment structure, our reimbursement structure, and that's like 90% of what we make is based on a for-profit, I don't know, full of benefits and great retirements and all those great things where people stick around for 30 years. And that's not the case anymore. Our competitors are for-profit. They pay, we just raised our minimum wage to $15 an hour. We're forced to do that. And it should be $18 an hour that drives these rates for entry-level folks. So we have many years to catch up on. We are committed as a leadership group at 7 counties and a board to meet those expectations, but we have to chip away at a little at a time, and we have to keep working with our reimbursement folks like the state and Medicaid to get the kind of rates that will sustain the kind of folks that we need to hire in here to do this quality work. This is not something, you go into this work for a mission, but you still have to pay your bills and provide your family with the things they need. And so, we work really hard to try to do that.
And let me, if you don't mind, Madam Chair, let me go down a little further. Representative Mosier mentioned about capacity. And like I said, y'all answered a very good response, and I appreciate that. But could you enhance that a little more in terms of let us know what your caseload is for a worker? Are y'all fully loaded? Are y'all 95% loaded or 70% loaded? We're trying to figure out what's capacity out there in terms of your current workforce. And we all need more social workers and licensed individuals, in our agencies. But could you give me a little better feel on that?
Yeah, I'm happy to answer that. At our community mental health centers, we provide services to those with Medicare, Medicaid, commercial insurance, that type of thing, but and services to those who have no funding source as well. And yes, there are still a good many out there who we encounter without insurance. But I will say on our child side, we have been able to keep our caseloads at a manageable size of 70 to 80. But unfortunately, on our adult side, our caseloads have gone well up over 100, sometimes to 150 and above for clinicians. And as we all know, that's not a good situation, and it's a difficult situation. Medicare, as many of you know, requires that the providers be licensed. And so that's where that shortage of independently licensed providers comes in and is problematic. And so the caseloads rise.
Thank you.
All right. Thank you very much for your testimony. We don't have any more questions, but we will make your contacts available if any members of the committee want to follow back up privately. All right. Next. Thank you.
Thank you so much.
Next up, we have the Department for Community-Based Services. They're going to go through their workforce challenges and initiatives. I hope that Marta Miranda Straub and Lisa Dennis are on the line, and if you all would introduce yourselves for the record, and let's giddy up and go.
This is Marta Miranda Straub, DCVS Commissioner.
And good afternoon. This is Lisa Dennis, the Deputy Commissioner for the Department for Community-Based Services. And I will go ahead and get us started. Again, good afternoon. Thank you for the opportunity to present on DCBS workforce challenges and initiatives. DCBS has over 4,300 employees that are located in all 120 counties across the state, as well as central office. DCBS is responsible for delivering services to families to prevent the disruption of the family unit and reduce poverty and adult and child maltreatment throughout the state. The delivery of these essential services for families and children are designed to protect individuals from abuse, neglect, and exploitation, and safety, permanency, and self-sufficiency as our paramount goals. Next slide. We wanted to take just a minute on the next couple of slides to highlight the volume of work completed by our social workers within the department. This slide shows the number of Child Protective Services intakes during the time period of October 1st, 2020 through September 31st, 2021. During that time period, DCBS received just over 112,000 Child Protective Services intakes. An intake is a referral or information received by the department to be screened and determine if it meets acceptance criteria for a report of abuse and neglect. Of that 112,000 intakes received by the department, 86,503 contained allegations of abuse and neglect that were screened by our centralized intake staff. And of those 86,500 plus referrals that contained allegations of abuse and neglect, 38,932 or 45% met acceptance criteria and resulted in a social worker responding to make face-to-face contact with the child victim and family. The last two columns on this slide show the number of referrals out of that 38,932 that we investigated that resulted in a finding of either substantiation or services needed and requiring ongoing case management. This means a case was opened and followed by our staff for a period of time for either in-home case management or out-of-home care services. Next. This slide looks at the number of children in out-of-home care. DCBS currently has 9,122 children in out-of-home care, which is a decrease of 925 from just over a little over a year ago of 10,047. This is a positive trend that we want to see continue and has continued post-pandemic as we are seeing our number of reports increase to those pre-pandemic numbers. This is also a positive indicator that the investment in prevention services is having positive outcomes for families and children. What is also important to note with regards to this slide is that of the 9,122 children in out-of-home care, that approximately 1,500 of those children are in a relative or fictive kin placement. DCBS implemented our new relative service array in 2019, which fully informs relative and fictive kin caregivers of their options of either becoming a child-specific foster home or a DCBS certified foster home. We made changes to our data management system, our TWIST system, to be able to track DCBS foster parents who are providing care for relative fictive kin placements. So if we look at our out-of-home care numbers, that the 9,122, and we separate the 1,500 children that are in relative fictive kin placements, we have just a little over 8,500 that are in placements with a foster parent. Next. DCBS is committed to ensuring quality services. Staff are focused on ensuring placement stability and ensuring the best placement possible is located for a child, as well as being focused on ensuring children in care achieve permanency timely. To provide quality services to children and families, DCBS is dependent on a valued, resilient, competent, skilled, and experienced staff. As we remain focused on recruitment and retention of qualified staff to maintain our caseloads, we are finding the challenge greater than in years past. Next. Here on this slide, we are looking at the average statewide Child Protective Services caseloads for our frontline caseload carrying social workers. This calculation of caseloads includes all cases. which means all referrals, investigations that are either current or past due. And it also includes all ongoing cases, including both in-home and out-of-home care cases. To get our caseload average, we divide the number of cases by the total number of staff that are at full capacity. Those are staff that are able to carry a caseload. At any given time, the department will have approximately 150 or so staff that are considered full-time employees. However, these staff are unable to carry a caseload because they are new or in training or on extended medical leave, desk duty, etc. So we remove them from the calculation and figure caseloads based on the staff that are actually carrying the cases. And this gives us the most accurate calculation and the most transparent look at caseloads. In addition to caseload numbers, we must also always take into consideration the complexity of the cases. No two cases are the same, and every case is different and requires a different response and approach from our social workers. Currently, workers are managing all types of cases. They are carrying low, moderate, and high-risk cases and complex cases. With caseloads as high as they are currently, it is difficult for staff to manage more than assessing safety and risk to a child victim and families. And there is less opportunity for staff to engage families and ensure linkages to available resources are made. The statewide average caseload, as you can see from this slide, currently in September is 26, which is better than what it has been in years past, but is still way too high. The Council on Accreditation and other national child welfare organizations recommend caseloads between 15 and 18, and some even as low as 12. And while the statewide average is 26, many areas of the state are experiencing much higher caseloads. For example, Jefferson's average caseload is 47, Fayette is 39, Hardin County is 36, and Warren is 43. And caseloads are continuing to trend upward for the month of October towards 28 as a statewide caseload average. You will also see from this slide that the average caseloads began to increase in June. And that is the same time that we began to see a significant increase in our turnover. Next. As was just stated from the prior slide, we began to see our caseloads increase in June of 2021, which is the same time that we began to see a significant increase in our turnover. This slide shows turnover for calendar year 2020 for the department overall, and then it's broken down by service region for all positions, all the 4,300 positions within the department. While the 2020 turnover numbers was significant, and we were trending with similar numbers at the beginning of 2021, we have seen a significant increase in turnover of staff leaving the department beginning in June of 2021. In the first 5 months of this year, January through May, the department had 240 staff exit. From June through September the 15th, the department has seen 397 staff leave, which is a 62% increase from the first 5 months of the year. And looking at our state fiscal year turnover data for our protection and permanency staff, our social work staff, our turnover was at 22.8%. With the number of staff leaving the department, we are also seeing the tenure of our staff decline as well. As of June of 2021, 44% of our caseload carrying social workers were in the job classification of a social service worker 1. To be in that classification, the employee has less than 1 year of professional experience. As social workers gain that year of experience and the skill sets needed, we reclass them to the position of social service worker 2. As of June 2021, 19% of the department's caseload carrying social workers were in the job classification of a social service worker 2. This equates to just over 60% of our caseload carrying social workers being in the 2 entry-level job classifications for the department. Next. And this slide looks at exit reasons, and it looks at it from over the period of 2019 through 2021. We see the top reasons listed for separation from DCBS has to do with better pay, outside of state government, retirement, insufficient pay, too many cases. And while these reasons for staff leaving the department are common trends, what we are seeing now is that COVID has changed our workforce in ways that we don't fully understand yet. The workforce within DCBS is stressed, it's depleted, it's traumatized, and our staff are making different choices. We have to listen to the reasons they are leaving and continue to make changes and investments if we're going to have quality, resilient, and competent staff that we want serving families and children as we go forward. And now I'm going to turn it over to Commissioner Marta Miranda-Straub.
Thank you, Lisa. Thank you so much for inviting us to present to you. This is a really crucial time for us in regards to workforce capacity and retention, and we want to educate you about what's happening, also what we're doing, and enlist your assistance. So DCBS has designed a culture of safety so that when a worker, we review a case and there was a fatality or near fatality or a mistake, we look at what are the systemic and structural supports that were not there for that worker, that supervision, that coaching, that training, as well as what that worker needed in order to make a better informed decision and to assess risk. We have infused primary and secondary prevention initiatives to get us out of crisis and begin to reach families before they hit the child welfare system, so that we can stop working with only folks who come into our emergency room, protection and permanency, after they're depleted, but being able to offer support and resources ahead, upstream. And we are infusing this work throughout all of our programs. We engaged in a 6-month stabilization plan when I got here. That is completed. That's gone from COVID-1 to COVID-2. What did we learn and what do we need to institutionalize to stabilize the workforce after COVID? What we learned as COVID-1, what happened? We engaged in an 18 months innovation plan to build a 21st century agency that included over 100 trusted advisors, that mean partners, existing clients and alumni clients, youth and family, with our both frontline staff and leadership to design programs that would decrease barriers and increase access, making the lived experience at the center of those designs. Those folks will be now institutionalized as a trusted advisor council and will work along holding us accountable and bringing the lived experience to our work. And then after that, we will engage in a thriving 3-year phase 3 institutional engagement plan that would hopefully be institutionalized so that regardless of who's governor, who's secretary, who's commissioner, we put in the best practice that we learned from COVID and what we've learned from the design, including our frontline staff and our trusted advisors. Next. So the challenge for us is that our staff, as I shared with you before, I come with you with over 35 years of secondary trauma and worker impairment, identification and prevention. So we have positions that our folks are continuously exposed to multiple traumatic events, the kinds of things that none of us want to talk about and nobody's want to see. They see on an ongoing basis. So when you talk about an 18 caseload or a 29 or a 23, those cases are incredibly difficult, and at least 20 to 30% of those are highly traumatized and complex cases. We have high risk positions similar to emergency medical personnel, EMS and police. However, we do not have administrative leave when they have a traumatic event. For example, one of our young workers was held at gunpoint for 4 hours by a client in a psychotic episode. We have others threatened and their family threatened that had to be relocated, et cetera, et cetera, et cetera. So we do not have administrative leave for those workers. They have to take their own sick time or personal time. And we have no hazardous duty retirement, which we highly would like to offer for these positions. We have toxic stress, which is the beginning of the continuum. Burnout is what happens after toxic stress. Then we engage in vicarious trauma, which means trauma is contagious. And then we move into compassion fatigue, where we're tired of caring. And we begun disengage, we begun to shut down from the trauma and the need of our clients, and that is not good for quality of care and for engagement and compassion for our families. And then we move right into secondary post-traumatic disorder, which is where our child welfare workers experience the same symptoms of our client: nightmares, not being able to sleep, anxiety, panic, depression, etc. The quality of services is diminished when our workforce is there. Our work capacity diminishes. Our retention is hard to do. And we have a high turnover. We have had a turnover. The statistics show us that a frontline advocate trauma worker, as well as a commissioner, last about 18 months. And after that, we're really not able to manage the work unless there's some institutional ways that we address that and we're implementing that. So we've had a turnover issue all along. We've had a low pay issue all along. However, we have gone from bleeding to hemorrhaging at this point. We have trauma triggers, and what we know from the research that when folks are traumatized, what that triggers is the desire to flight and to leave work, which is what's been happening for a while and what has really been aggravated post-COVID and post the fact that our staff has a lot more opportunity to work at a back store or as a bartender, making a lot more money than what they make working with us and working with the highly traumatized and demanding cases that we have. Next. So initial response when we first got COVID, our staff turned on a dime. Remember that we always maintain a physical presence. 20% of our staff continue to deal with high-risk cases, children who were at risk or alleged at risk, and families in crisis. We've never not done that and done that face-to-face. We did it in parks and we did it in backyards and front porches, but we did it. But 80% of our staff went virtual, and we continued the in-person for those high-risk cases, families and children. What we saw, and we were incredibly surprised because we've never done this before, was an increase in performance. They outperformed the year before. We reduced residential placement. We increased placements with relatives and fictive kin, which we wanted to do and is best practice. We engage in expanding ongoing prevention. We expanded services, supports for transition age youth. And what happened here, it is not related to child welfare, but you need to know, we went from our call center doubling and tripling the amount of calls that we were able to answer as a result of working virtually. I think we do about 1,000 a day. There's a 7 to 10 minute wait at the most. We used to handle four, Lisa, you can correct me, for 4,000 to 5,000, I believe, and we had like a 30-minute wait. So could you correct me on those stats?
Pre-pandemic, for our family support call services, we were struggling to answer 4,000 calls a day. Today, we are answering 10 to 11,000 calls daily to help serve clients with those needed public assistance benefits.
Thank you, Lisa. So we were surprised. We looked at the performance, we looked at the outcomes, we looked at what we were doing, and the staff outperformed from the year before when we did not have COVID. So we were doing well. We got a respite where we thought we could get out and we can begin to go to soccer games and eat at restaurants. And then we got hit with the Delta variant. So the second wave hit an already tired and exhausted staff. Like many of us, we thought it was behind us, and it isn't, and it wasn't. So staff was exhausted and now are feeling incredibly anxious. There's an incredible amount of uncertainty. Many of us are dealing with grief as a result of death of staff, co-workers, and family as a result result of COVID. We have a depleted workforce, and we have increased our high turnover, and we have a low recruitment. So even folks are not even applying for jobs because what our pay is minimal, and it's not competitive with any other employer. We're doing pay equity and looking what others are paying, and looking at all of our work and competition. And, state government is not competitive in regards to that. So anybody that could retire has. Our workforce is young and new. And we are having a hard time recruiting, even though we use social media. We use trauma-informed language to talk with our staff. We have instituted secondary trauma as an institutional priority for us to develop support for our staff and training around that. However, the reality is that we are carrying higher caseloads than we want, and that is best practice for our clients. And we're also are not paying staff what they need. We're not paying a living wage. A lot of our staff qualifies and receives SNAP and TANF, just like our clients do, although they work full-time for state government. Next. So here is our vision, and I like you to know that we have not received a capacity increase or a raise in a very long time. We kind of foresaw that and asked the governor and the legislator for that last year, and we were not successful at getting what we needed. We were trying to be proactive around this crisis. We're now in crisis and on triage, and we need your support when we come to you in being able to maintain a healthy and robust workforce. So we want to create both a robust virtual and in-person workforce. On June 11th, we opened every public-facing office so that anyone could be seen in person, as well as continue the virtual, which is so successful. Our clients continue to make appointments, continue to use the call center, continue to show up for trainings at double and triple the amount that they did prior to us being able to do that, because they don't have to drive, they don't have to spend money on gas, etc. We're working on reducing our brick and mortar because we have instituted a hybrid model. This does two things. It gives our workers an opportunity to get out of the fire and be able to come in, do face-to-face, but also step down and work from home and do their administrative work, their research, their call, all of those appointments and trainings that could be done on Zoom, and then be able to come back in and do face-to-face, recharged and renewed. So it provides a better work-life balance, and it keeps our staff energized. So we are looking at open concepts so that folks can come with a laptop, plug in, make copies, meet with a family, and then be able to go home and use their home office as a way to work. We have looked at work-life balance, and offering that flexibility has been touted as a staff as one of the top benefits of working for DCBS, and one of the top learnings for us as an agency about how to continue to not only support staff and work-life balance and minimize secondary trauma, but also continue to increase performance. So we are reviewing, revising, and modernizing all features of the physical conditions of our buildings. We have buildings that really are not conducive to seeing clients, mold, leaks, et cetera, et cetera, et cetera. Every building is being looked at. Every decision is being made about what those clients need and that community need, and how many folks need to be in the face-to-face. And we are reducing the brick and mortar and fortifying the virtual experience, and doing both at the same time. We want to be a living example of who we are as an agency, treating our families, clients the same as we want our family treated, and being able to develop a robust and healthy and resilient workforce and organization. Next. So here's some of the pieces that we've put in place. We have increased focus in institutionalizing secondary trauma and resilience as a goal, a second pillar of that 21st century work, putting self-care as part of the work, not as a side thing, not as a luxury, but as necessary when you're doing trauma work, which is what all of us who've been working with trauma, and this is my 45th year, actually 46 now, in working with this, is what we know. we're adding debriefing groups right immediately after a case, a circle of support that folks can debrief. We're using KEAP, our employee assistants, to provide debriefing groups and to provide one-to-ones with our staff for short-term support, referrals to needs that the staff may have, and providing stress management assistance. We are focusing on prevention and moving upstream and engaging in learning about what secondary and primary prevention looks like, because we need to stop working in crisis. Our clients are in crisis. We cannot be in crisis at the same time. And we're looking at alternative response. And this is a really important piece of why we need capacity. We don't just need bodies. We need highly skilled folks who have experience in complex trauma. They will carry the most difficult, challenging traumatic cases, maybe have 10 to 12, and then act as content experts and support and coaches for our newer workers who are young and do not have the experience. They will have larger caseloads, but would not have to deal with the highly traumatized that they do not have the expertise for. So we not only need the increase in pay to provide a living wage and competitive wage to retain staff and to recruit staff, but we also need capacity and expertise around dealing with complex trauma. Those people with highly experienced work in how to deal with a real difficult challenges that our families and children and youth have. Next. So statewide support for our staff. We have provided alternative work schedules. A lot of folks were working from home and their kids were not in school. So folks can work an alternative schedule and choose an alternative schedule that met their needs. Also, that was coordinated with supervisors and the team based on what the needs for the region and the county and the families were. We included a hybrid workforce. We asked personnel to institute a hybrid workforce, both in person and a virtual. We are doing a skill and competency-based training. We have provided basically an academic training. We've worked with EKU about really identifying what are the skill sets, the values, and the core competencies that anyone working for DCBS, whether you have a social work degree or a history degree, that you need to have in order to be competent to be able to do our work. That curriculum has been designed and will be in process next year. We're digitizing our records. We have provided field training specialists, pilot programs. We're looking and organized regional committees and workshops, and we have statewide initiatives with partners, bringing the C back into DCBS so that we are not a one-stop, the only emergency room, but we are part of the community and providing those community wraparound prevention services that support our clients and youth, but also support our staff. Next. This is my last slide. What I want you to understand is this is the best practice elements that our agency has adopted. Client-centered services, individualized case plans. We're not McDonald's. Every case is different. We're looking at strengthening the parental capacity, how to empower fathers, how to empower non-custodial families, how to provide the support and the coaching and the mentoring that young families need. Really develop collaborative, high-impact partnerships, not just paying agencies to do the work. For example, we're doing great work with Mary Hurst and really partnering with Our Lady of Peace and with Home of the Innocents, with VOA, Volunteers of America, so that we extend our capacity by joining resources and expertise. We're looking at cultural responsiveness. We're outcome driven. We're measuring performance. We measure it during COVID. We're measuring it again. We need to. And trauma-informed service, not just for our clients, but for our staff, using language. Our staff is traumatized and depleted. So they are reactive. They are a lot of times don't feel cared about, don't understand why they don't get raises, and why it's been a long time since we've had the capacity and the raises that they need to stay at the job. And everything we're using is an evidence-based practice. So thank you for listening. Thank you for being interested, not only in our families and children, but understanding that our capacity and our expertise is needed to be able to continue the work that we're mandated to do. Thank you.
Thank you very much for your presentation. That was, well, you have a lot of challenges, and you really are the linchpin of kind of making this whole thing work. So we need to make sure that you are empowered to be able to do your job to the best of your ability. One of the things that kind of kept going over and over in my mind as you were presenting, particularly when it comes to the workforce issues, we talk about retention. We can't retain workers. They're traumatized. They're, energy depleted. They don't have the proper pay scale that we think they deserve for the job that they do. How are you going to present those adjustments that you recognize? Are you going to present the General Assembly with a reorganization bill? Are you going to present us with a new salary scale? Are you going to present us with, how are you going to let us be partners in this in this problem that we have?
Representative Moser, thank you. Yes, we have worked with our budget, and we did this last year, and it was not approved by the legislature. So we're going back in for both capacity and alternative response. As I mentioned, that expertise team, as well as a raise increase. We're looking internally at pay equity and meeting gaps over time, because folks have not received raises in a long time, or they one group received raises and another one didn't, which created an incredible amount of disparities. The secondary trauma and the institutionalizing self-care as part of the work, not as a separate thing, is part of what we're also doing, as well as the training for the effective skills and expertise that everyone needs to have, the reduction of caseloads, and being able to be competitive to not retain the folks that are staying with us, but also be able to attract competent folks to join us again. Because as I said, just like all of state government and the rest of the country, we have a lot of people retired. This COVID kind of was the cosmic 2x4 by a lot of businesses and nonprofits. People said, why am I doing this to myself if I can retire? I have a master's level social worker who I did an access interview with. She said, Commissioner, I love the work, I love the people, but I'm making double as a bartender working half the time than I did working with you. So that's kind of the challenges that we have. So we are coming to the legislature. We've sent it to the secretary. He's looking at it. We're sending it to the governor. And then hopefully will be integrated in the governor's budget, so that when you all look at how to support DCVS, we put in the pieces that we believe we need that are basic for a foundation to be able to rebuild our capacity for staff and continue to move forward on both primary and secondary prevention and not ever be in this crisis again.
Okay, thank you. So you envision a budget, your request coming through the budget bill, but you will not be presenting the legislature with a reorganizational bill. Is that correct? Is that your answer?
We are presenting for adding a division of primary and secondary prevention. That's the reorganization piece. That we're presenting to you all. But the rest of it is budget related. It's capacity and, living wages. So that our state workers are not able to, not living on SNAP and TANF, and don't go to work at a box store or a bar for a lot more than it is to take care of our vulnerable families.
Okay, we have
children.
Representative Mead.
Thank you, Madam Chair. Thank you all for your presentation today. I have a question, but very quickly I will address one thing, Commissioner, that you said you came to the General Assembly to ask for raises. That is absolutely true. Those raises were discussed in our private budget meetings, and the discussion was upon giving the frontline workers their raises. The answer that we received back, or some information that we received back from DCBS and the Cabinet, was that their main concern was the pay disparity. That one thing that was sent back to us was that we didn't want social workers making more than supervisors. We understand that, but maybe with the stress level that these folks are facing and the situations that they're put in, maybe they do need to make a little bit more money. Maybe pay disparity is not what we need to be worrying about right now. Just focusing on the issues that where we need to get workers right now, where we're lacking. But my question to you is, you mentioned in your presentation that you're wanting to go to more virtual meetings in certain low risk situations. So what constitutes a low risk situation that a virtual meeting is acceptable as opposed to an in-person home visit?
Right. So thank you for what you said, and we totally agree with what you said. We're also looking at pay disparities so that the grades, people are not competing with each other. So we are looking at those pieces internally, and that's on us, not on you. So what we're asking for will not create those kinds of issues. Secondly, low risk cases is when a child or a family is not in danger, when there has been no issues that a child is a potential neglect or abuse, of that a family is in immediate crisis. All those cases, not only now, but during the pandemic, have been seen and will continue to see in person. Now we have a lot more, all of our public facing offices are open. So we have in-person staff that can create cases, see cases, see people, make home visits, etc. So for us, as of June 11, we have increased all of our public facing appointments and all of our capacity to be able to see people in person. But I do want to remind you all that we never stopped seeing families in crisis and children at risk in person. So things that happen is, for example, foster care training. Things that happen is evaluation of services. What's going on with the rest of the children? What other resources do they need? So things that are not crisis and do not present a risk to the family or the child. And also follow-up. If someone has completed treatment and they now are reporting on what's happening, those kinds of cases are the ones that we provide. But remember, it's hybrid, which means that we have both in person as well as virtual, and a lot more than we did during the pandemic. It was 20% in person and 80% virtual because of the pandemic. As of June 11th, that has changed, and we have workers in all of our offices in every county that are in person, where folks can be seen in person, regardless of whether they're in crisis or not.
Thank you. And one follow-up question to something you just said. You said that it would be in some of those cases where there is no evidence of abuse or neglect. If there are cases with no evidence of abuse or neglect, why is the cabinet even looking into those families?
Because we're really looking at that collateral family. We're really looking at the secondary prevention. These are families that maybe got reported because, for example, discerning between poverty and neglect is one of our goals, all right? Poverty is not neglect. Sometimes a family just needs food and needs to be referred to food assistance. Sometimes a parent or a foster parent or a child in foster care needs extra support to be able to do those kinds of things. So we're not just dealing with the crisis of maltreatment, we're also trying to help rebuild families and rebuild support for families before they need us or before there is abuse and neglect. So we are now engaging in a lot of that work to support families upstream. So yes, we do deal with neglect and abuse, and those will continue to happen. However, we need to get ahead of the game and begin to support families before they're depleted, while they need less resources. It's a great return on investment for families and for DCBS.
Senator Berg.
Thank you again, Chairman Rocky. Thank you both for a very interesting and clearly heartfelt presentation, a very informed presentation. I hate to ask this question because it's not going to be an easy question, and I feel like I'm adding insult to injury. But nationally, they reported this last weekend, I believe, that we have approximately 150,000 children in the United States who have lost their primary caregiver to COVID. I mean, that's going to have a tremendous generational impact. 150,000 children lost their primary caregivers to a virus. Do we have any idea in the state of Kentucky how many children we're talking about and what type of services we need to be anticipating will be needed down the road as a result, and what we can do to jump in sooner rather than later and protect these children from, the inevitable consequences of losing their primary care provider as a child.
Senator Berg, excellent issue. I will let Lisa speak to that. She's my operational person, but that's part of our commitment to kinship care and to supporting foster parents and to fictive kin. We're increasing all of that. We continue to increase all those resources because we have the opioid crisis. So a lot of folks are dying from addiction more than we did prior to the pandemic, suicide as a result of the pandemic. And then, of course, we have the pandemic and people getting ill. So more than ever, we need that support system of fictive kinship care, as well as foster care to be able to take care of those children and youth. And Lisa may have some more specific answer to that because she has the eye on the prize.
Unfortunately, no, I don't have a more specific answer to that question. We don't know yet. Like I said earlier, we're still learning about some of the impacts of COVID and what it means for families and children, as well as for our workforce. But as the commissioner said, we are committed to increasing services for our relative and fictive kin caregivers and have additional supports available to them and to assist as needed. And like I said earlier, the expansion of our relative service array really is benefiting those relative and fictive kin caregivers today.
Senator Berg, do you have a follow-up?
Yeah, thank you very much for your answer. And I would just really encourage everybody to start thinking, how is this going to increase our need for services in the next year, 2 years, 3 years? Because it's not just that we're behind the 8 ball already. We're getting further behind. Every day, this pandemic is putting us further behind.
Thank you. Representative Fleming?
Thank you, Madam Chair. Commissioner, Deputy Commissioner, appreciate some of your comments. I would like to just ask a couple questions about your comments, but going back in history, I believe the General Assembly allocated maybe $5 million-ish that was allocated for allocating for retention and pay. Whatever happened to that money?
I believe that was in 2017 budget. I'm not exactly sure which budget year that was, but the salary went to that funding went to increasing salaries of our frontline social workers and supervisors.
100%? Yes. Okay. I hear contrary to that, but that's okay. In 2019, there is a WAVE did a segment on the caseload that was skyrocketing in Jefferson County to I guess basically through the roof. So some of the policies and the allocation that was sent to you all in 2017, 2018, it appeared that I sort of questioned if what y'all implemented worked, given that report that was on WAVE back in 2019. Could you comment on that?
I'm sorry. So the report that we provided to on WAVE 13 in 2019, as far as what we're doing.
WAVE TV did a segment on the department and how the caseloads were through the roof. And part of that was some money that was allocated to help retain and increase pay. But to me, some of the strategies that y'all applied to it may not have worked. Could you explain that?
Well, one of the strategies that has been very successful from that period of time was partnering with some of our partner agencies to supplement the workforce in Jefferson. We partnered with KVC to help with completion of our referrals, particularly our past due referrals. And that contract has continued, and we are looking at ways to expand that relationship with them now to address some of the imminent staffing needs in Jefferson, as well as we also contracted with another of our partners to help support some of our foster parent recruitment training and home study writing. And we're looking at ways to expand that contract also to to better support our staff in Jefferson.
Okay, well,
And not just Jefferson, but throughout the state.
And I know it happens throughout the state, but I guess I'm really focused on Jefferson, and I appreciate you're looking at that. But you know, looking at one thing and doing another are two different things. And you've got a contract involved, and I'm not too sure why that hasn't been implemented, because when I asked a question to y'all's department a couple of weeks ago on the Health and Family Services, I got a response back to around 37 caseloads per worker. And that, and you know, is above the statutory requirement of 24. In fact, it's even higher than the national average. And when I go through the calculations on a report that I received based on what y'all have, I've got around 68 cases per workload based on 2,886 cases. And that includes supervisors. And supervisors, my understanding, should be supervising, directing, and assisting, but not actually doing the casework. So if you take those folks out, now you're looking at 85 cases per workload, per person. And that's rather discouraging in terms of finding that. So why haven't you implemented that contract now instead of telling me that you're looking at it?
We have implemented that contract. It's still ongoing.
Excuse me, but why? And I'm sorry, I'm being a little cut you off. But why is the caseload increase if you're implementing that contract and you're supposedly getting better results? But reports I'm looking at is not the case.
From 2019 to where we are today, there is a significant decrease in caseloads. In 2019, during that report with Wave 13, we were reporting some caseloads as high for workers in Jefferson as 60 and 80. The average now is still way too high at 47, but we have made progress. And actually, we were even as of earlier this year, those caseloads were in the 30s. It's as our turnover has begun to increase that we've seen the caseloads increase not only in Jefferson but across the state. And we have continued to contract with KBC and other partners, and we are been in conversations with them about increasing their capacity to provide assistance. And so that's not something that was new. It is something that's ongoing, and we are looking at, again, expanding that contract to continue to support more in different ways than what they have been up until now.
One more follow-up question, Madam Chair.
Sure.
I appreciate the comments, but this is, as you said, this is an ongoing problem. And I feel like Bill Murray in the Groundhog Day. I keep waking up and seeing the same old problem without finding a solution. And I'm getting rather concerned that there are children out there that aren't being taken care of, and they could be in a dangerous situation, if not a fatal situation, and not taking care of that and researching that and helping out and so forth. So I'd like to see a little more better results in terms of what's going on with that. And I'll be quite honest with you. This is my personal opinion that if there's not any action that's going to be taken in terms of reducing this to more of a manageable level, and I'll say like 24, 20, something like that, then I'll be looking at drafting some legislation to basically go through with the chairwoman mentioned about reorg, or trying to find some language to get that down, because there was a contract that was done some time ago to look at backroom operations, to work with the private sector, particularly when it comes to nonprofits, to help support that, so your caseworkers can actually do the work and not be burdened with all the paperwork, the backload situation. So you can actually do those things. So that's one thing I'm going to start looking at if we don't find some results in the next couple of months, because I think y'all said it before, we need to act now. And if what I can see in terms of when you come to the budget, come to the budget committee, I'm going to be looking for what y'all going to be doing with that. And I can tell you that I will put some stick to the language that if this not perform in terms of having results in a certain time period, then your funding is going to be reduced or impaired in order to reallocate those to to actually serving what we think needs to be done. Thank you, Madam Chair.
Thank you. Representative Mosier?
Yes, thank you, Madam Chair, and thank you, Commissioner, for your comments. I think that Representative Fleming hit on a lot of what I had to say, but when I'm looking at slide 8, where you're talking about the various phases of the primary and secondary prevention initiatives, are these really addressing the current crisis? I mean, is this, I know that we have some short-term fixes and some long-term fixes that need to go into place. It seems to me that these are really addressing some of the long-term issues that we have, and I do recognize that you have a very difficult task. But what sorts of improvements are you actually seeing that are addressing this current crisis? And I think this is what Representative Fleming was really getting at, because we're all hearing the same thing from our social worker friends and our constituents and our folks who are working in this area, that the caseloads are continuing to increase. We have a continuing problem with burnout, and I think that's probably what your long-term goals are addressing. But the worker shortage, you've talked a little bit about recruitment. I think these long-term fixes might address the retention, but it doesn't really address the fire that we have right now. I'm looking at your stabilization plan. It says that I guess you worked on this for 6 months and that it's completed. So I guess, what exactly did this stabilize?
We will be glad to send you that and share that with you. What I must tell you is that we must do both. We need to take care of our worker shortage. We need to take care of the low pay. We need to take care of the trauma, while we're also taking care of families and children. We are depleted in regards to the number of staff that we have to do that. And we're not able to retain staff because we're not competitive. So those are the challenges of now. However, when we engage in prevention, that is now. If we get a family ahead of when they need to go to protection and permanency, we do not have the highly traumatized caseload. When we actually provide resources to a family or a child before there is neglect or when there's neglect but no abuse, we're actually reducing caseloads. We were very successful about reducing caseloads. We were about 26 until we hit this second wave between June and now of people retiring, exiting, and being able to leave for better paying jobs at box stores and at other situations. So we are and must do both. The short-term crisis, the whack-a-moles every day, the retention of staff, the being able to support the staff that is staying, and how do we do that? The hybrid model, the work-life balance, the secondary trauma, the bringing in experts that will be able to support our young workers to do that. However, we also need to start getting folks before they need child welfare and before there's neglect and before there's abuse. That would reduce the crisis, reduce the caseload, and will be a good return on investment. So for us, that's what's needed. The basics of protecting children and families, being able to do that work. We need a qualified and stable workforce to do that. This has been a problem for DCBS for a long time. They just have gotten aggravated. And secondly, we need to look forward to how do we do things differently so that we're not in this crisis 20 years from now and come back to you with the same issues that I'm sure multiple commissioners have brought to you before in regards to workforce turnover. The training is in there, and that is short term, the being able to offer support for staff to get permission to practice self-care, the work-life balance, the being able to step off the fire and being able to both work virtually and in person, as well as beginning to think upstream. Maybe we have tunnel vision when we're busy and burn out. We keep doing the same thing, expecting different results. We haven't engaged our community partners in new ways in wrapping around our families so that they're not just DCBS, but all of us working together. So these strategies in both the short-term stabilization and what our trusted advisors and partners helped us design is how do we increase and I must remind you that we outperform ourselves last year in regards to the number of people that we saw, the amount of benefits that we gave, the amount of calls that we went ahead and answered. So although my staff has been depleted and tired, they have been performing well. I'm just think we're at a crisis right now, particularly at this moment where we need to make some structural changes. And we'll be glad to share with you what the goals of that stabilization plan was, including frontline staff in all of our meetings, including the lived experience and folks who we serve with us as we design new ways of evaluating and holding ourselves accountable. So we don't have to wait for one of you to hear from a family about how we didn't do well. We're hearing from them now as we revitalize how we do our work and how we walk along with clients and with our partners.
Okay, thank you very much for that answer. I mean, I completely agree that these are long-term fixes that we need to really be looking at. And I understand, the whole COVID situation has really set all of us back in many, many ways. And that it takes time for these initiatives to really take hold. So I appreciate what you're saying. I really agree with the primary and secondary prevention initiatives. I'm also looking at the intake slide 2, where you talk about some of the intake, and we don't necessarily have to take time today to talk about this, but we're getting a whole lot of calls. Over 112,000 calls in 1 year, and only really having substantiated cases at 11,000 and 9,000 respectively. So, I'm curious about who screens the calls, who's triaging these calls. Are we having to utilize social workers for this purpose? Are these taking social workers out of the field who are working directly with families, and also what's the threshold for families who are entering the system? So I think those are all maybe things that we can discuss. I would like your input because you're really experts in this field as to more than just the funding aspect, because I think that you are hearing from folks, you are working with the folks who are on the ground and hearing, really about the families and what's going on with the families, what these thresholds are. It seems that there would be some policies that are driving things, I don't know, perhaps in the wrong direction. So anyway, thanks for your input. Looking forward to talking to you more about this.
Thank you, Representative Mosher. We have one last question, Representative Beckler, and we are so far off track on time. So let's, if we could, please ask your question, if we could keep the response tight.
Thank you, Madam Chair. You've mentioned competitive wage a number of times. What do you consider a competitive wage, and where are we now?
Yes, thank you very much. We looked at what our nonprofits in each area are paying workers, including bonuses to sign up, as well as looking at, so where are folks going to that are getting paid more? So we're looking at it externally, comparing that, as well as looking at internally where the pay disparity is, because sometimes some of the workers got a raise appropriated by you all, and others did not. So that keeps growing year after year. So that's the pay equity study that we're doing internally and externally. We're also looking at what it costs geographically to live in each of our regions, to pay rent, to be able to eat, to pay our utilities. And we're looking at somewhere around, in some areas, for example, Jefferson County, the living wage is somewhere between $16 and $19 for folks to be able to pay rent and live there. In some of the rural areas, it's less, 14 to 16. So we're also looking at what is a living wage, meaning what does it cost for a family of one or a family of two or a single person to be able to pay their bills, their basic bills, to live in that area. So that's what we're using as a comparison. And then we're looking at what our staff is making. We have family support staff making $29,000 a year, et cetera, et cetera. So we're doing all that internal work, looking at every position, looking at the salary gaps and the pay inequity over time, as well as externally, what are other partners paying, including sign-up bonuses, as well as private agencies such as back stores and fast food stores who are paying $16, $17 an hour, and we're not.
I understand you're looking at it. When are you going to have an answer?
Well, we actually did that work, and actually that's part of our proposal in regards to recommendations for raises. And internally, we're looking at what we need to do in regards to salary adjustments and reclassification, and I'm working with personnel and OHRM to be able to make some of those internally. Some of that is our work, but we really need to be able to pay state employees a living wage, and that's somewhere between $15 and $19 an hour, depending on what county you're in.
Thank you, Madam Chair.
Thank you, and thank you all for your testimony today. I appreciate it, and please expect some follow-up because I do think that we will have some. And as I said before, we're ridiculously off schedule as far as time goes. So we're going to call up right now Western Kentucky University Life Skills, Austin Griffiths, and Joe Dan Beavers. If you all could introduce yourselves for the record and please proceed. You can go ahead and get started if you'd like, since we're behind on time.
Appreciate it. Austin Griffiths, Western Kentucky University.
Joe Dan Beavers, President and CEO of Life Skills, Bowling Green, Kentucky.
Thank you all for being here.
All right, let's just get on to it. So if you want to go ahead and pull it up, that'd be great. My name's Austin Griffiths. It's certainly an honor and a privilege to be here today. We're going to get to the point. I used to work for DCBS for several years. It's definitely an honor and privilege to be here today. I'm excited to bring or to be here with Mr. Joe Dan Beavers, President and CEO for Life Skills. Thank you very much for your time. A little bit about me. There's a couple
and
slides.
We do have this in front of us.
Very
if we can't figure out the computer, we do have this in front of us.
So we're going to walk right through a few of these things because I really want to share about the hope and the progress and the things that we're doing at Western Kentucky University with our new center. And that's really kind of the gist of what we're trying to do today. So long story short, on that first slide, it really talks about me. I just wanted y'all to know that I used to work for the agency. I'm really passionate about this work. I come from DCBS. I worked at CPS, APS, worked for almost 7 years. I earned my MSW at Western Kentucky University. I've worked for WKU for several years, earned my PhD in social work at the University of Kentucky. And since that time, we've created a center, which is now called the Life Skills Center for Child Welfare Education and Research. And that's what we're really talking about today, and we're really excited about that. So along that path, driven by focus on helping, assisting the workforce, of which I have worked for several years. It's really been about doing that stuff. So let me flip through a couple slides here. Started with a pilot study, moved forward, helping the agency across a couple of administrations on doing a large needs assessment and really having a kind of a trajectory of applied research. So I just wanted to mention that, just to give a background. This talk is certainly not about me, but I think it's relevant to what we're talking about here. So building this alliance, it's really the point of this quick conversation that we're going to have today. It's really become very apparent, especially where we're at in Western Kentucky and across this state, that there's been a need for an alliance, building a community, building this approach to support this child welfare kind of mission. No doubt child welfare belongs to all of us. So in June 21st of 19, we created the Center for Child Welfare Education and Research. We weren't given a ton of money or anything. It was an idea and a passion and something that we wanted to move forward with, and we did that. So our mission is certainly supporting the development of child welfare professionals to serve Kentucky's families and children. And we just simply believe that we can do more together. So I'm going to share a couple slides that talk about our team and our mission real quick, but I think it would be relevant before we talk into actually the work that we're doing and kind of sum things up. So we have a shared focus along with Life Skills, who's certainly been a trusted partner and a premium healthcare provider in Kentucky for many years. We've heard 7 counties speak earlier. No doubt it's a similar sister agency, but this is in the Bowling Green, Hopkinsville area. Obviously, President CEO Mr. Joe Dan Beavers could speak more if he needed to, but I wanted to mention a couple of things here. We've only been around as a center for a little over 2 years, but we're receiving consistent, people that are reaching out, agencies that are reaching out, other people that are saying, how about this? How about this? What can we do? We've heard about y'all. This is really exciting stuff. Y'all are moving forward. So we're really excited because Life Skills believes in us and our work. And so we're creating this alliance here at Western Kentucky University with a large community mental health center to work together to support families and children in Kentucky. And a huge piece of that is clearly the workforce, and that's what we're going to talk about today, about what we're actually doing, what we've been doing for a couple of years. So as you can read here on the slide, certainly not going to read it, but this immediately increases our capacity, resources, things like we now have an office space. Y'all need to come visit us in Bowling Green. We now have an office space. We have supports for research, scholarship, hiring graduate research students, and we now have a manager. But another cool thing is this opens doors for us to interact and engage, to create and utilize evidence-based practice with a premium healthcare agency on our side of the state. It's a great model, and we're really passionate about that work. So wanted to mention that to y'all. You can naturally see this information here, but Life Skills and the Pennyroyal Center had a merger, so they've expanded. We're really excited that they believe in us and we've partnered, because originally the whole design of this center was to build a team, to support and increase the support for child welfare in the state of Kentucky. And it's exactly what we intend to do. I'm the director, if I didn't mention that. So we're really excited about that. But Life Skills has been a trusted partner for years. I've known Mr. Beavers for a while. And we're going to talk about a project that we're doing right now that's directly helping the workforce along with the Kentucky's child welfare system with this DCBS. So this is just some information about their expansion. I'm sure y'all are very familiar with this, but I did want to mention this and kind of show this illustration as we slip through some of these slides. A little bit about our center. I think it's relevant. There are several child welfare centers in the country. Ours, we wanted to be very strategic and intentional. So we have a 5-pillar approach. You can read here. We've got a focus on education and training, workforce development. You can read here. But each one of these pillars is led by a member of our leadership team. And I'm going to show these folks real quick as we slip through. So myself, I'm the director. We've got Dr. Bawama, DeRozier, Sullivan, and April Murphy. These are all social work faculty at Western Kentucky University. So our leadership is social work faculty, but the great thing about our center, which is why I believe we're making progress and individuals and community members are excited about our work, and I hope you are too, that's why we're here, is that it's interdisciplinary in nature. It's not just about social workers. It's about bringing people together to make and improve the child welfare system, families and children. So we have the number of scholars that are faculty members at Western Kentucky University, psychologists, speech language pathologists, nursing, medical professionals. These individuals, Dr. Woodward, Weiler Green, Song, Lickenbrock, Redifer, and Link are here also mentioned. Now, I do want to mention this for the record. This isn't a social club. We're very intentional about the things that we do. We have a lot of research projects and a lot of activities that are happening right now. And it really matters to me as the director and as somebody that worked for the agency and that is dedicating my life to this work. This isn't a social club. This isn't a line on a resume. We're doing intentional work to improve things. So I wanted to mention that. And also we have...
Your beard is different in your picture than in real life.
I'm also sweating right now. Let's go.
But I digress. Go ahead.
Thank you. Appreciate it. Lighten me up a little bit. All right, cool. With that said, we've also got research affiliates. So we've connected with some individuals that are involved in some really fascinating work across the country. Dr. Whitney Cassidy-Kaywood is a faculty member at Murray State. Mr. Oliver Beer is finishing his PhD at Ohio State University, and these are examples of our graduate students, so a research assistant. So I just wanted to mention that to our audience here, that this is really important stuff, and we're really excited about it. And this is an example of what we can do to move forward as a state and nationally about bridging the university, bridging the community, and leveraging resources and expertise to make a difference on behalf of the system. And I'll just put it like this, because we're going to talk about this next slide. When I worked for the state, when I was a child welfare worker, when I was in Hart County, and I was one of 5 frontline workers, I felt like all roads led to me, and I was responsible for child welfare. I felt that way. It's kind of emotional, right? So with that said, we need to involve the community. And so there's a piece here with the second part that I want to talk about for a minute. The supporting the DCBS workforce is not only supporting those that are doing the work, but it's also being preventative and reducing the amount of work that's going to end up on their plate. So that's what we're going to talk about for just a couple of minutes, is reducing what we would call unreasonable expectations, because as, let me get the name right, Senator Higdon appreciated that when we started today. When Senator Higdon talked about those individuals that came in and talked about their experiences and the difficulties that they were experiencing, I felt that because I've been there. And so when I left the agency in child welfare, I left because I didn't feel like I could make a difference while I worked there. And that's why I'm here today, because I want to make a difference. And I felt like I couldn't do it while I worked there. And that's what drives me. And so that's why we created the center. So with that being said, the research is clear. Workers are still clear. These unreasonable expectations, we talk about pay for sure. You know, the pay needs to be higher, but you can't expect someone to, the pay might be what it is, but the expectations are completely unreasonable for any amount of pay, no matter what the pay is. When you can never unplug, you can never breathe, you feel like you're responsible for everything. Perception is reality, right? There's extreme things going on here. So with that being said, we're going to talk a little bit about it. I like this quote from the Upstream book. We've read this parable many times. I'm going to go upstream and tackle the guy who's throwing all these kids in the water. That really resonates with me. I think it's really proactive stuff here. So appreciate y'all's time. I'm going to hit a couple slides up and we'll be good here. So what are we actually doing rather than just talking about it? Well, we've only been around for 2 years. There are things that we're actually doing at our center. We're forging a community alliance. I believe that creating the center in and of itself is proactive. We've developed what's called the Community Engagement Series. The Community Engagement Series is an opportunity. We just had our first one. Dr. Bawama led it, where we have individuals from the community. We started it virtually. We're going to have a hybrid stuff, and we'd encourage anyone to come, where we're focused on creating community-wide solutions for working with immigrant and refugee populations. What an idea. Did y'all know that Bowling Green is very diverse? Sure is, right? So that's what we wanted to do because there's a need. We just started it probably 2 weeks ago. These are just things that we're doing to build that community and build that alliance and move forward. As you can read some of these. Another example I want to give for the sake of time is what's called the GIFT Initiative. So the GIFT Initiative is evidence-based practice for parents who have their own trauma. I remember working for DCBS for several years, and we would work with children. It was crisis triage work. We were doing our best to work with children, but we would send these children back to see their parents, and the parents themselves had unmet needs and trauma, and it continued this cycle, So this is actually free evidence-based treatment for parents that we're doing with the Child Advocacy Center down in Bowling Green. It's really good stuff, so maybe y'all don't know about that. We really want to expand that. We're looking for avenues to do that. It's great stuff. I wanted to talk to y'all about that today. The dissemination of knowledge, it matters to us that we're sharing information that we are developing ourselves, whether it's applied research, trainings, tutorials, all of this practice stuff, and not just for academics, for foster parents, for other individuals that are passionate about this work, that it doesn't just hang out in a silo and what one like me might call the ivory tower, right? It's accessible. So we're creating avenues that people can have this information. It really, really matters to us. The Child Welfare Advocate is a blog on our website. Here's a simple request. We'd love for y'all to put some information on that for us. These are things that we've just started. So we know that our community is desperately trying to hear about child welfare related information. And so is what we've called the Kentucky Legislative Spotlight. What are some laws? What are some things that are happening here in Frankfort, which a lot of our students or a lot of our practitioners or a lot of our local folks don't get to come down here about as much? What can we do to share this information so we can hear about it and build that community alliance? Last thing I'll say before we go to the next slide is really about harnessing that passion, and I can say objectively, this proof of concept has been established. We have really just absolutely trying to build something special at Western Kentucky University. We're really, really passionate about it. Supporting the workforce directly, the heroes that are still doing this work, my absolute heart goes out to y'all. Stay with it. Advocacy, collaboration, and innovation. So we've created an annual awards ceremony. As a veteran, people thank me for my service at times. My wife's a nurse. People generally thank medical professionals for their service. No one's probably ever thanked me for my service as a child welfare worker. It just doesn't happen. So I think it really matters. So we created our own annual award ceremony. And further, one of them, we've created a community award. It's called the Angela Lane Community Award. And it's after Angela Lane, who's an amazing leader in child welfare that works for DCBS in the Warren County office. So she's still there rocking it. So shout out to Angela. We're also hosting the 2022 National Title 40 Roundtable, which is a huge national child welfare conference. I would love for y'all to be there. It's going to be in May in Bowling Green. It's something we're really excited about hosting. We've never done anything like that. It's great. Not only the traditional training things that have been happening with PCWCP and CFL and seeing how those play out, but we've created a Child Welfare Career Expo to have DCBS and other agencies come in and have access to our students for purposes of jobs and trainings and other things at Western Kentucky University. But right now we're working with WKU's XR Lab to develop a really innovative, patented, interactive simulation platform, which really will shape the future of child welfare education and training. It's some fancy stuff. We're really, really excited about how that will take shape. There's some stuff in the works with that right now. You can read the rest, but I do want to spend my last couple of minutes talking about Child Welfare Workforce Wellness Initiative, which is certainly new, it's unique, and it's receiving international attention. So that's what I'm going to wrap up with today. I've got 2 infographics and a slide, I believe. So this is part of the State University Partnership Program. This is a work that is new, it's unique, and it's focused on evaluating and improving child welfare worker job stress. And the unique thing about this is it's not only about self-reported job stress, but it's using biometric instruments to truly capture the effect of job stress of these child welfare workers. Make no mistake about this. This isn't a secret, and this isn't even related to Kentucky. Job stress and child welfare has been significant for years. It's known, and it's not a secret. But what Kentucky's done is stepped up, and we're tracking this stuff. So this is a collaborative effort that we have between Life Skills, CHFS, Western Kentucky University. So we're really excited about the benefits here, because if you're talking about getting in there and not only assessing for the presence of real stress, quality of sleep, heart rate variability, and these challenges that these workers are having day to day, hopefully people will listen, right? Hopefully people will listen. These folks are falling apart and they're getting sick because this is happening. People in the field know this. We know this every day. We've experienced it. But having data, having evidence, that leads to advocacy. That exactly leads to advocacy. So with that being said, just wanted to mention that this is ongoing. I would be thrilled to come back and present data on this at any point in time. We're right in the middle of data collection. There's a little bit more I can share about that, but we're using biometric technology. There's some stuff that I'm not in the middle of ready to talk about just yet, but this is really innovative. People are around the country and internationally are looking at Kentucky as a leader here, because we're actually collecting data on the presence of job stress on behalf of the health of these workers, those that were willing to do it, which is really, really unique. It's great evidence to have. These individuals are able to participate during work hours, even though it's challenging. We know it's difficult, but the agency supports this, and we put in a mindfulness-based intervention. So we're using a mindfulness-based intervention that we're using remotely. And there's a lot of evidence about mindfulness-based interventions. Doesn't mean it's the only way, but look, there are very few interventions about improving the health and wellness of child welfare workers. People aren't even really trying it. I mean, maybe they are, but there's very few opportunities that people are getting out there in the weeds and just trying to make it happen is exactly what we're doing. So we're going to start with that. We're going to refine it, and we're going to see what works. And if it does work, it might be incredibly fruitful use of money to help people be healthy, to help people be more responsive to their clients, and to improve the system, and certainly primarily improve those that are working to help to benefit the lives of families and children. So last thoughts on that. This is a unique scenario. I really wanted to share with you all this unique research project that we've been working on as far as the State University Partnership. This profound stress, which has kind of been an overarching theme here today, it's not unique. It's an international problem. Really thankful to Team Kentucky for allowing us to get in here, and we just see incredible value in shaping policy and practice on behalf of this evidence from this. And I just wanted to mention to y'all that we're really thankful today for letting you know that at Western Kentucky University, we're trying to do the right thing. We've built a team that's really passionate about improving the welfare of families and children, period. It's not about me, it's about us. It's about what we can do. So if there's anything at all that we can do to help, that's what we intend to do. It's not some line on a resume. It's not a social club. This is intentional, strategic work. And this is exactly what I'm going to keep doing. So I appreciate y'all's time. I'll take any questions you have.
Would you like to say anything?
It's hard to follow that. And I think that, it's really easy to pick out when people are smart and talented and passionate about what they do. And I hope if you guys didn't pick up on that from Dr. Griffiths today, I got to spend, an hour with him when he was pitching all this to me initially. And, you guys got a brief version of it. You get to spend an hour with him, you'll be a true believer. What he's doing and what this group is doing there in Bowling Green is really best in class thought leadership and applied research. He's been very humble about that today too, so I'll brag on him. It's been recognized already nationally and internationally. He's had a chance to speak, I believe, at it was a virtual conference maybe in Europe. So I mean, folks are paying attention to what we're doing in South Central and Western Kentucky here, and to me that's, and I take zero credit in this. I'm fortunate just that we were able to be part of this today too. But I think when you can find folks like this, they're smart, talented, passionate about what they do. You get them together and let them do what they do. And my role in all this has been to try to support wherever we can. I think the work is powerful and impactful. I know earlier today I actually made a note, and I hope she was still able to stick around and listen to some of this. But Commissioner Miranda Straub mentioned, one of their tasks, her quote was institutionalizing self-care. Well, this is an option. Like this is a direct, answer and response to that problem. What he's talking about, and what we see to connect this with Abby Drain and my colleagues at 7 counties and some of the others that talked about the challenges that we're facing. Some of the questions you guys asked about our workforce challenges and our issues. We do have openings in clinical therapy positions at Life Skills and Pennyroyal right now, and it's a challenge. Pay is clearly part of it, but we know it's not the only thing. If we don't change the environment or provide some of these additional supports, increase in pay will help, but it'll be time limited. Eventually, if I'm still unhappy with my job, a raise will help me, but I'll still be unhappy with my job. And so things like this are critical for all of us. I think it's very applicable to what we're talking about today with child welfare, but it's very applicable directly to us in community mental health and probably lots of other healthcare workforce issues that our state and country have faced lately. So I think this is really exciting. I'm glad that I think as time progresses, Kentucky's going to be seen as a potential leader here for the work that Dr. Griffith and his team are doing. It's really, really phenomenal. And we thank you for your time today.
Yeah, and I appreciate this testimony. I just have one question. What's your funding model?
We're ready for y'all to give us money. So it's exciting because we have the freedom to pursue our interests, which are simply to improve the lives of families and children in Kentucky. So our funding model was we wanted a name, and that was it. And we started with that. And we wanted to be free and clear from any pressure or anything else. And we wanted to follow our intentions. And we've done that. And throughout good work and working hard, now we'll achieve grants, which we are, that will support us. We've partnered with Life Skills, who has partnered with us for the next 5 years, that has paid our operational costs. And so we have a space, and we have a manager, and we have some other supports, and through the College of Health and Human Services at Western Kentucky University. So there's a partnership there. But we're going to take it strategic and slow, and we're going to keep doing meaningful, important work, which is what we're doing.
Well, I love your presentation, and I love knowing that this is out there, that this has been created, and it's methodical, supportive, and I really do. I applaud you, and I look forward to continuing, hopefully, partnerships in the future as we really navigate, trying to get everything, back on track. Because as it's been said 10 times today, our kids are worth it.
Right.
So thank you.
Right.
Any questions from the committee members? If not, I'll move on. And I do appreciate you hustled through that and you gave us all the highlights. So I appreciate that.
I told you I was in the military, so.
Yeah. Okay, next up we have, where are we? Okay, number 6, Department for Community-Based Services, Workforce and Secondary Trauma. We've got Dr. Jay Miller, and he is in person. Dr. Jay Miller, please come up, introduce yourself for the record, and please proceed.
Having me. Okay,
Yeah,
pull up. So my name is Dr. Jay Miller. I am the Dean of the College of Social Work at the University of Kentucky. I'm also Director of the Self-Care Lab, which I'll talk about here momentarily. Like Dr. Griffiths, I'm also a former CPS worker, so did investigations in Jefferson and Hart counties. But perhaps most importantly, at least to me, is I'm a loud, proud foster care alum. So I grew up in foster care, spent time in kinship care. So as you might imagine, the concept of workforce challenges and worker wellness is kind of central to me, and having the experience of, number one, growing up and being in out-of-home care, being a CPS worker that removed kids and placed them in out-of-home care, and now being in the space to do research about that concept and how to improve those systems has been really both rewarding and humbling to me. So I know the hour is far spent, so I'm going to breeze through a bunch of stuff. I'm more than happy to provide some backside information in the event that I need to. Can you? How do we advance this? There we go. Got it. So a little bit about the self-care lab. So the concept for the self-care lab came about several years ago. It's the only known entity in the world that's explicitly designed to address the issue of burnout among helping professionals, i.e. social workers, teachers, nurses, etc. And as many of you know, the concept of worker burnout is now an epidemic as defined by the WHO, CDC, etc. And so it really impacts the way that we do a lot of our work. That being said, I don't want to repeat what others have talked about, but child welfare workers are increasingly faced with challenges related to the work that they do. And we've heard a lot about compassion fatigue, secondary stress, et cetera, et cetera. We've talked about caseloads. I do want to highlight a difference between the concept of caseloads and case weight. And I think some folks touched on it earlier in the sense that what is also true is that our child welfare workers are dealing with much more complex cases. I remember as an investigator, a worker referral would come in as an educational neglect case and would end up being a sex abuse case that I had to remove kids on. And so the case weight is a really important factor when we think about how we help workers to manage the stress related to their job. I also think it's really important to point out that public child welfare workers are disproportionately impacted by broader things that happen in the community. I always say child welfare isn't a someone problem, it's an everyone problem. And as such, we need everyone involved in that solution. There is nothing more frustrating as an investigator than for it to be 5 o'clock, it's time for me to go home, and I'm sitting on the phone making referrals to community mental health agencies that can't take my family because they're full and don't have the resources to do so. So while we often talk about worker wellness in the context of the cabinet, it's extremely important that we talk about the broader systemic community resources that help those workers do what it is they need to do. And so that can't be lost on us as we talk about how to better support our workforce. We also know that these workplace conditions that folks have talked about and associated consequences impact retention, which we've talked about. Now, there's a really important thing that we must understand is that workers of today, in general, are not the same as the workers of yesterday. So the days where a worker used to come and stay in a career for 20, 25 years, those days are over. So we have to kind of reframe the way we think about retention. And I always ask the question, folks say we have a retention problem, and I always say, well, how long should one be retained? And that's really a question that in child welfare we're grappling with, particularly as it relates to some of the differential roles. Being an investigator frontline, going and knocking on doors is a very, very different role than sitting on the hotline and taking calls. Now, it's not to say that it's any less important. Both are equally important, but it's just a different type of job. So I think we have to acknowledge that as we think about not only the retention, but the recruitment of workers and getting them into the workforce. Morale, and then I would be remiss if I didn't talk about the concept of service provisions, meaning if workers are not well, they're not providing good services. And we could cut that any way that you want to, but at the end of the day, a burned out, jaded, traumatized worker cannot do their best work, no matter how much training they've had. So we need to understand that we need to support workers, number one, because it's the right thing to do, but we also need to support workers because it's a support for Kentucky families and children because they're going to be able to provide a better service. Just to talk really briefly about some of the partnership work that we've been able to do with DCBS. Several years ago, through the Self-Care Lab, we launched a pilot initiative designed to tackle this concept of professional burnout among public child welfare workers. One of the things that we did, because we, like Dr. Griffiths discussed, we're really interested in kind of evidence-based concepts. I think a lot of times, in child welfare, we just kind of throw things to the wall and we see what sticks. We didn't want to do that. We wanted to set out to be very strategic in thinking through and conceptualizing an intervention that we could launch to help workers deal with the stresses that they were faced with. So we embarked on a multi-year project related to conceptualizing an intervention, and we started that with conducting a comprehensive needs assessment as it related to wellness. So we went about the business of collecting data from public child welfare workers around the concept of burnout and wellness, and here's what we found. So I'm a stats nerd, so I won't bore you with that part, but this is a scale that runs from 0 up to 35, okay? So higher scores are better. And when we did this in terms of trying to measure worker wellness by region, because we wanted to be responsive, we found that different regions were experiencing wellness in different ways. Now, let me be clear, none of this is good. The average score is about 30, and we're sitting at about 21. Big difference in terms of the way we think about wellness. But I think what's also important here is that you see some of the workers that struggle with wellness or burnout the most are ones in rural areas, the lakes, Eastern Mountain, et cetera. So it's almost like the further you get away from Frankfurt, the worse off you are in terms of thinking about the concept of wellness. We also wanted to really track the impact of COVID. We must understand COVID has fundamentally changed child welfare service, not just for now, but forever. As the commissioner discussed earlier, they are brainstorming ways to think about how to leverage some technologies and such that they've conceptualized and developed as a result of COVID. But what we know is that COVID has impacted even the regions differently. And if you look at this map in comparison to the last map, the thing that you will find is that COVID has impacted our rural areas of the state in a bigger way than it has our more urban areas. And the reason for that is back to the concept that I said earlier about community resources being available, et cetera, et cetera. So we know that, number one, workers were struggling with burnout wellness. Number two, we know that COVID-19 exacerbated that in many ways that the data show. And so we wanted to put together a conceptual intervention that we could deliver with child welfare workers to assuage or address some of those problems. So we went about the business of conceptualizing this project. It was very important that we did it from the perspective of child welfare workers, meaning any of us could sit around at a desk, scribble out some things that we're going to do, and then go do it. We wanted to go about the business of collecting data and information, using that to conceptualize this wellness intervention, and then launching it out to child welfare workers. In short, what we found is that the intervention for the workers that received it was beneficial in a number of different ways. And I can provide this on a backstory later should you need it, but we found significant improvements in some of the research that we were doing around the knowledge and confidence to engage in self-care and wellness practices, which is really an interesting concept because we assume that people know how to be well, or we assume that they know how to take care of themselves, and we found that they don't. And so we took time to really try to increase what we call self-care competency, meaning knowledge, skills, and values associated with wellness. We were able to boost confidence to engage in those practices, values associated with engaging in those practices. One of the things that child welfare workers face is kind of this helping profession curse, meaning you're doing it for the good of everyone else, so you shouldn't worry about yourself. I remember as a worker, I thought that my needs were last and didn't factor in at all. So I would stay as an investigator, I'd work all day. At 4:30, I'd go night assessment. I'd work till 12 o'clock at night. I'd sleep in my office and start back the next morning because, again, I'd been in foster care. I knew what the work needed to be, and I dedicated myself to that work. But after about 6 or 7 years, I started to feel different about it because I was burned out and jaded. So having the value and understanding that the work a child welfare worker does is important, and it saves lives. We talk about doctors and nurses and teachers and all those things, and those are great. But our child welfare workers are the ones that make sure those kids get to school safely. They make sure they get home safely. And so it's important that we get to a space where they value themselves enough to engage in wellness. We also show, and data showed, and again, I can provide this in more detail later, that we were able to reduce burnout, secondary trauma, and what we call paratraumatic distress. And that was really related to COVID. So paratraumatic distress is the concept of stress during an instance. We often talk about post-traumatic stress, meaning something that's happened afterward. paratraumatic distress is the stress you feel in the middle of a situation. So we were able to reduce all of these things by paying some systemic attention to an intervention that we were able to go out and do. It took about 2.5, 3 hours for workers. One of the really interesting challenges we faced is that just being away from the office for 3 hours meant that work was piling up on your desk while you were gone. So the concept of you can't be well because you have too much work to do was not lost on us. One of the things that we did is we adapted the intervention to be more virtual and on-demand. And then we really chopped it up. I think historically folks have looked at these types of intervention as, well, come get away for 3 full days and we'll go through these trainings and concepts. As a worker, you don't have 3 full days to be away. So we kind of chopped them up and really worked on delivery and accessibility related to the intervention. And now that we've put it in the virtual space, we're able to do a lot more with it in terms of reaching a broader amount of workers. We've also talked about family support staff, so the folks who, KTAP, et cetera, who do all of those types of programs, delivering it to those folks as well. So in terms of what we're going to continue to do, again, we're working on the build out. We want to continue to ensure that this is available to workers and that it's they can engage with it as they see fit, meaning having a training at 9 o'clock in the morning doesn't always work for everyone, so we want to kind of make it adaptable and offer it to a broader constituency. We're also going to continue to work with DCBS on ways to more effectively streamline the concept of wellness as a culture. So from the outset, day one of your work, how do we go about ensuring that workers are socialized to the concept of avoiding and mitigating the impact of burnout? And then we want to continue to leverage some of these existing frameworks that we have, thinking about what is already happening, some of Dr. Griffith's works, et cetera, in the state, where we can kind of leverage to collate and pull together some of this work so that we can more efficiently deliver it and make sure it's accessible to folks, again, when they need it. So ultimately, I think we have shown that we can address some of these concepts of burnout. We've also shown that in doing so, we can address the quality of service. It's just really important that we're intentional and mindful about what that looks like and that we understand that it's going to take a broader systemic approach. The cabinet alone and our DCBS, they've done an excellent job in kind of managing through the COVID situation, but ultimately it's going to take a broader constituency if we're going to tackle some of these challenges facing the child welfare workforce. All that said, I'm happy to take any questions, comments, concerns, and or celebrations.
Okay, fantastic testimony. The one thing that kept popping up in my mind that I wanted to ask you is, how do you feel your reach is statewide? Do you feel you could be broader in scope, or are you comfortable with kind of how you're reaching out to all different parts?
Well, so as of now, we've delivered the first wave intervention in every single region.
Okay.
But of course, you know, a lot of it is just kind of how you formulate it in a day of a CPS worker.
Right.
9:30 Jefferson County doesn't work because you're sitting in family court all day.
Yeah.
You know, so one of the things we've really been working on is how to break it up to be more accessible. And the virtual space, and this is one of the possibilities of the pandemic is what I'm calling it. We've been able to move to a virtual space that allows for more on-demand type interaction. So you might not have 4 hours to come to something, but if we can get you for a 20-minute intervention, what might that look like? And so that's where we are now in terms of being able to deliver it more broadly. But yes, our goal is to say that every worker in the state has been able to have access to this intervention. And if they take nothing else, it's that they value the work that they do and understand that their wellness is important.
Well, I like that. I like that flexibility and how what you have and connecting that with the individual that is in need. So that's a really positive thing to hear. So thank you.
Thank you.
We have Representative Beckler.
Thank you, Madam Chair. I have 2 questions, and they don't relate to each other. However, they do relate to the conversation here. Doctor, you've been through the system. You've done a remarkable job. In an effort to try and see what works, my question is, outside of your individual strength, to what do you attribute your success in going through the foster care program?
Well, I think it really boils down to me for reframing foster care. Foster care is not something we do to children and families. It is a service we provide to children and families. And as such, we must try to make it the best service possible. What helps me is knowing the alternative. If not for foster care, I would have remained in a very abusive home. So when you reframe it and look at it more as a service, and can it be improved? Absolutely. That will always be the case. But I think far too many times we don't think about the alternative. And so reframing foster care to be a service, that's what has helped me. And so I had great workers and I had not so great workers. And that just kind of goes with the territory. But when you see it in relation to where I was, or where a young person is, or where a family is, it just helps you view it different.
Were you moved from family to family, or were you, okay?
I was in, this was the time you'd be in a foster home, and then you'd be with a relative, and then you'd be back home, and then you'd be back with a relative. So we were shifted around a bit.
I really admire what you have been able to accomplish.
Thank you.
My other question goes back to the worker wellness slide and the impact of COVID-19 slide. If I've interpreted the slides correctly, on the worker wellness, the 19.52 is worst and 21.32 is best. Is that correct?
Yes.
All right. The lakes are 19.74, Eastern Mountain 19.52. Now, if you go to the next one, the impact of COVID-19 worker wellness, once again, my interpretation is that the negative 5.65 is the best, is the worst, and negative 1.360 is the best. Is that correct?
Yes, so it's the differential. It's saying how big of an impact has COVID had. So the 1.3 is a bigger impact, the 0.56 is a smaller impact.
Well, then my question gets down to the lakes and the Eastern Mountain. It seems to me that those are wide changes. They started out about the same, and now the difference is quite dramatic. Have you been able to make any come to any conclusions about what that is and why it happened?
Yeah, so we're working on several pieces now that kind of get down in the weeds around factors that contribute to that. What we are finding is that, number one, it's the availability of community resources in those areas. And in COVID, you saw some entities made the shift a lot quicker than others. Interestingly, what you also see is some court practices, meaning accessibility to family court dockets, et cetera, a lot of the data would indicate that some of those things impacted stress levels for workers. But we're also looking at a number of contextual factors that would kind of explain some of the variance that we were seeing. But ultimately, it boils down to the community context. There's certainly some management or supervisory practices. But again, I think, as the commissioner indicated earlier, the state was able to turn on a dime. And I think from a national perspective, because I work with several other states around child welfare wellness concepts, Kentucky did a really good job at making some of those shifts in a very short time frame. But some of the community resources didn't shift as quickly. And so again, that puts stress and strain on a lot of the workforce if you have families and you're not able to get things to them. Or in the virtual space, we assume everybody will have access to virtual capacities and such when they don't. So all those things create stress for the workforce. And we're in the space where we're looking at and examining the context around some of these places and why there might have been some variance as it related to COVID.
So in very simple terms, one part of the Commonwealth did a better job in turning than the other one.
I don't know if I would say it like that. I would say that one part of the Commonwealth was impacted by different contextual factors than another part. So again, If you look at the service array in the lakes and the service array of Eastern Mountain, those look very different. And so if you start off in a place where there's already limited resources, and then you have to make this shift, and the limited resources are not able to keep up with the capacity, or there's more need for that service, then you're going to have those contextual factors that are going to impact worker wellness.
Thank you. I'm just surprised. I'm from Western Kentucky, far West Kentucky, and in the Lakes region, and I just find it surprising that we were better off, if I interpreted correctly, than the eastern part.
Well, no, actually.
Or is it the other way around?
Yes, the other way around.
Okay.
So there was a bigger difference pre-COVID and post-COVID for the lakes. The lakes saw the biggest difference, meaning stress got higher because there were more desperate outcomes as it related to some of the stress.
That's what I would have expected. Thank you. Thank you, Madam Chair.
Mm-hmm.
Thank you. And we do not have any more questions. So you were fantastic. Thank you so much for being here and presenting. And as I've said to the other ones, I would expect some follow-up as we kind of pull together a lot of this information going forward for the 22 session. Last but not least, Jill, we saved the best for last. That's what I say. So we have Jill Parker and Dr. Diane Lally. And
thank you so much.
Yeah, just tell us who's who, and please proceed with your testimony.
We will, and we will be very brief. My name is Jill Parker. I am the Executive Director at Eastern Kentucky University's Training Resource Center.
Hi, and I'm Dr. Diane Lally. I'm the Research Advisor for the EKU Training Resource Center.
And we were asked to present just some very high-level sort of ideas about ways that we work with DCBS and some data that we've already talked through, but we have some additional data to share about worker retention. So that's our presentation this afternoon. So first of all, EKU has had a contract, unbelievably, with DCBS for 38 plus years. We primarily provide training for the workforce for both protection and permanency, family support workers. We also provide training for foster parents. We also have a very massive training records system that tracks the required training for both workers, for parents, and even for child care workers, so that those are all documented. And I'll just make a little highlight quickly here. Part of it was a question earlier about the DCBS strategic plan and what we did during the 6 months. So during that 6-month planning, one of the things that we began to really heavily look at is what is the training need for the new workers coming into protection and permanency? How has that shifted with COVID? What are the needs today? Commissioner mentioned this earlier. We realized that some updates were drastically needed. We need to focus on skills. We have partnered with the University of Louisville and developed what we call anchors that describe what workers need to be able to do today to be successful as a worker within protection and permanency. We're building a new training system that is very focused on equipping these workers with the skills they need. We don't want to waste time. We want to really get in depth with the things that we've gotten feedback on that they need to know, and they need to know how to do well. And so in February of 22, we will be rolling that out. Tied to that, and a part of the strategic planning that's been going on with DCBS, we are going to be developing certifications for both workers going through training, workers as they go out into the workforce and work in the job. That will be tied to the field training specialists and other. We're going to be very creative about what we do to equip. That's our goal. Equip these workers and to put them in the best place we can. We know their stresses, but we're trying to equip them in the best way so that they're ready for the work that they've got to do. The third bullet on this page is we have other ways that we support DCBS through the contract. And one of those is to help with some surveys and some data. And so Dr. Lally is going to give you some high level information about some of that information we have.
One of the ways that we support DCBS is through the development of the Employee Engagement Survey, which is in partnership with DCBS. It looks at things like staff satisfaction, how staff feel about their role within DCBS, how they feel about the organization as a whole, how they feel that it is working or not working. And then we, at the TRC, we do a couple of things with the survey. We look at data analysis, both qualitative and quantitative. So looking at the numeric information, but then also the shorter answers that are provided through open-ended questions at the end of the survey. And then we compile a report of this data, usually a month or month-ish after the survey closes. So this survey has been distributed across a few years. It's not distributed every year, but the most recent survey was distributed in 2018. And about 46% of the workforce responded to this. This is a voluntary survey. It is anonymous, but workers don't have to participate in it if they don't want. So there were a couple of measures that were really high as far as the mean score that workers rated themselves, where a 5 is the highest and 1 is the lowest. And so those measures related to self-efficacy. So if they feel like they can do their job well, and adaptability, that they can adapt to the job using those skills that they have, both of those were consistently high across regions and across in comparison to 2016 and 2018 data. However, measures related to staffing and stress were both among the lower measures, and that is also across 2016, 2018, and across regions and across all different types of workers. So the biggest barrier to completing quality, risk, and safety assessment and prevention plans across the life of the case for workers was reported to be workload. 81% of the respondents on this survey reported this as a top 3 barrier to completing the quality, risk, and safety assessment and prevention plans. So this fall, we're going to be distributing the 2021 survey. Very excited. Last year, due to COVID, there were a lot of competing concerns and making everything virtual and making that work, that the survey was delayed a year. But it includes an updated set of questions that are more focused, laser focused on employee engagement. Also questions related to secondary trauma, self-care, mental health, and then also asking if workers know about resources that are existing in DCBS that they can access. So really kind of, do workers know what's available, and then are they feeling like they're in need of those services? So accessing that kind of data. So this data collection is going to occur in October, hopefully in the next week or two. And a final report will be available after that window closes. So we usually give the workers about a month to reply, a couple of reminder emails, and then we have another month-ish of combining all that data into a report for everyone. Separately, we also look at staff separations and retention data. So this is separate from the employee engagement survey. This is kind of looking at the opposite side of the coin. So we have the engagement piece, which is how workers are feeling about the job and themselves. And then the other side of the coin is why they're leaving. So we have a couple of years of data represented here, 2019, 2020, 2021, and kind of has been the discussion all afternoon. We're really seeing those separations increase starting in 2020. And it's that green line that's just really increasing. We don't have data or the full data for August and September, so we didn't want to put that on here, but it's definitely increasing. And then finally, the last slide demonstrates reasons for staff separation. These are the most frequently reported separation reasons. And so again, this is from 2019, 2020, and 2021. And these are in rank order. So those items at the top of each column, those are the most frequently cited reasons for workers to separate from their position. In a lot of years, you can see that reasons are pretty consistent. They're pretty much the same. We're looking at better jobs outside of state government, insufficient pay, those types of things. But then we move into 2020, we start seeing early retirement creep up. And in 2021, especially, we see health reasons, family reasons. All of those types of ideas are starting to creep up.
I told you we could be brief. Are there any questions? Anything we can
You are
explore?
you are a woman of your word. I really
I try.
appreciate
I
it.
try really
Yes.
hard.
And again, this committee meeting has really been fantastic, I think, because we've gotten some really good information and really good feedback. You know, one of the things, and this is a commentary, is, you know, you've had this contract in place. Do we get a copy? Do members of the General Assembly, are they allowed to, the contract has been in place for 38 years. Do we ever receive this, or have I just missed it over the years? And if I have, I think it would be good to.
I think you have people on staff that can answer that more knowledgeably than I can. I know it is, the LRC sometimes is involved with questions, but I don't know how far that goes to be presented.
Yeah, I mean, for
to individual legislators.
Because I think that this is good information. For instance, you know, you say in 2018, one of the most pressing issues for our personnel was workload. Well, we're in 2021 and it's workload. And so, you know, I think this is good for us to see things like this and be reminded, okay, we haven't fixed workload yet. You know, are we going to contract out the back room part of workload? Are we going to, you know, how are we going to fix this? So anyways, my thought is I think you do good work and I would like to see more of it. And so I will noodle around in the LRC and see if we can't make sure that we get members of the General Assembly a copy of this.
We'll be happy to share.
Fantastic. Okay, and unless I have any members from questions from the members of the committee, I think that we are finally adjourned for the day. So without objection, we are adjourned. Oh yeah, Monday, November 8th at 1 p.m. Monday, November 8th, 1 p.m. is our next